Okay, hello everyone. Hello, welcome back, and thank you all so much for coming to Parkon this year. My name is Claire Bale. I'm Associate Director of Research at Parkinson's UK, and I'm delighted to be leading us through this session, where we'll be trying to answer a very big question indeed. Where are we in the search for better treatments for Parkinson's? Now, I'm very pleased to say I'm not going to be responsible for answering that question on my own. I have three fantastic guests joining me. But before we get to that, I'm going to set the scene and explain a little bit about the background of where we are in Parkinson's more broadly. We also really want to hear from you in the room and also people online. So if you have questions or comments for our speakers, we hope to leave time at the end for discussion. So if you're online, please put those in the chat. And if you're in the room, raise your hand when we get to that part of the session, and our people with microphones will try their best to find you. Okay, so first of all, what is Parkinson's and how do we treat it currently? So Parkinson's is a condition that primarily affects the brain, a very particular part of the brain called the substantia nigra, and that's where dopamine-producing brain cells live. They make a chemical called dopamine that helps to communicate the messages our brains send to our muscles to help us to move. So as these brain cells are lost gradually over time, it gets harder and harder to do the movements that we would usually do with ease. So whether that's handwriting, walking, smiling, every part of movement can be affected. But Parkinson's isn't just about movement. We know there can be over 40 symptoms, and these can include things like mood difficulties, anxiety and depression, for example, difficulties with fatigue and sleep, constipation, pain. The list is almost endless, and everyone is affected differently. In terms of current treatments, we already have a range, particularly of medications, but also other things that can help to mask the symptoms and improve life with the condition. But most of these treatments work by topping up the levels of dopamine inside the brain. So those brain cells that are struggling to make their own dopamine get a little boost. They're able to send the messages that they're struggling to send on their own. And that can help to ease the symptoms, particularly the movement symptoms. But unfortunately, what current treatments cannot do is they cannot slow or stop the progressive loss of dopamine-producing brain cells. And that means the condition will continue to deteriorate over time. And as that happens, that means people need to take more medication. And with more medication can come side effects and more challenges. So what we desperately need is treatments that can do more than just top up dopamine levels and mask symptoms. We need treatments that can actually address the root causes of Parkinson's and slow, stop, or reverse the progression of the condition. Unfortunately, decades of research are helping us to get there. So we and many others have been funding research for around 50 years to try and uncover the causes of Parkinson's. And the reason that we're doing that is so that if we don't know what's going wrong inside the brain, it's very, very difficult for us to find treatments that can fix those problems. So I just want to give you a little overview of some of the key things that have been discovered over the last 50 years or so that we think are why dopamine-producing brain cells are dying. So on this slide at the top, you'll see mitochondria. Now, mitochondria is a fancy word, but essentially these are the tiny energy-producing batteries that are present in almost every cell inside our body. They turn the fuel from our food into energy that our cells need to do their jobs. But we know in Parkinson's that mitochondria stop working inside the brain cells that are lost in the condition. The second one is inflammation. Now, inflammation is a really important process for us. It helps protect us from infections, get rid of foreign invaders inside our bodies, so it's vital to our health. But sometimes inflammation, if there's too much of it, can be damaging to our bodies. And researchers have discovered that inside the brain in Parkinson's, there seems to be excess inflammation, too much of this good thing, which might actually be accelerating the death of dopamine-producing cells. The third one on the list is alpha-synuclein. It's a protein you might have heard of because we think that alpha-synuclein, this protein, might be the rogue protein that starts Parkinson's. Alpha-synuclein is an important protein. It's present in many of our cells and does important jobs. But for some reason in Parkinson's, it starts misbehaving. it changes shape, it becomes sticky, it starts sticking together and causing problems inside brain cells, including the development of Lewy bodies. Fourth on the list is recycling. So just like in our homes, it's important for us to take out the recycling, get rid of waste, take out the bins. We don't want our houses to get full of stuff we don't want anymore. And the same thing's true in cells. They've got lots of things that they need to get rid of, and they have very complicated processes in place to help them do that and identify which things need to go. In Parkinson's, those processes seem to stop working properly, and that can lead to the buildup of excess waste inside cells, which puts additional pressure on those struggling brain cells. And finally, at the bottom of the list there, but central almost to all of the others, genetic factors. Now, Parkinson's is not usually an inherited condition, something that's caused by a single change in a single gene. But over the last few decades, researchers have uncovered many genes that might be playing a role in making people more vulnerable to developing the condition. And many of the genes that have been identified play roles in those things that I've just described, whether that's mitochondria, inflammation, recycling, or alpha-synuclein. So we're starting to be able, with all this information that's been gained through research, to put together the jigsaw puzzle of how and why brain cells are affected in Parkinson's. And that knowledge is powering a development of new therapies for Parkinson's, things that can do more than just top up dopamine. And we're going to talk about many of those treatments in a moment, but I just wanted to quickly give an overview of how we turn the treatments that are being developed in the lab and get them into people living with Parkinson's to test if they really do work. And we do that through clinical trials, which I'm sure many people have heard of, and probably many people are already participating in. But there are three main phases to clinical trials. In phase 1, this is the first time that a treatment has ever been given to people. So it's a very crucial stage because the most important thing to know is this treatment safe for human beings to take? So these phase 1 trials tend to be quite small, a few people, and quite short. But undertaken in very controlled conditions. Sometimes you have to stay in a facility while being part in a phase 1 trial, because the researchers are looking to see how is this drug processed by the body? Where does it go if it's a pill, where does the drug end up in the body? What are the potential side effects? And what is the safest dose or the dosing range that we think is safe? If phase 1 goes well and your drug looks like it is safe, you can move into phase 2. And phase 2 is where it starts to get really interesting, because you're starting to look at that drug in people with the condition you're interested in, so Parkinson's for us, and not just looking at safety, although that's still very important. You're also starting to look, does this drug do what we hope it will do? Is it potentially effective and potentially able to slow, stop, or reverse Parkinson's? In phase 2 trials tend to involve more people, be a bit longer, and will usually involve two groups, a group that get the real treatment and a group that get a dummy version, so the researchers can compare the two. If you're successful at phase 2, it means you can move into the final stage of clinical trials, which is phase 3. These are the definitive studies where you have to gather the essential evidence needed to prove that your drug is safe and effective. These trials tend to involve hundreds and sometimes even thousands of people, so they're very large in scale, often across many countries, and they tend to be quite long as well, sometimes many years, because the researchers need to gather so much evidence to prove that the drug is safe and effective. And if that's successful, that evidence can be presented to the regulatory authorities and then hopefully the drug approved and made available to everyone with the condition. So hopefully I've shown you that we're in a good place. We've learned a lot about what's going wrong inside the brain, but clinical trials are a challenge. They're long and they're complicated, but I've got some really good news. We've got lots of treatments for Parkinson's that are already in clinical trials, and we're going to talk about some in just a moment. But I just want to give you a little snapshot of what the drug development pipeline looks like for Parkinson's. So this is not just in the UK, this is a global picture. So at phase 1, each of the little pills represents a clinical trial. So there's 39 clinical trials happening right now across the world in Parkinson's. 39 in phase 2, and 3 in phase 3. So many fewer in phase 3, and there's reasons for that. It's hard to get to the end. But we are aware there are more coming and making it to phase 3 now. I'm now going to pause and welcome my special guests to come up to the stage to join me so that we can talk about some of the trials that are underway right now and the ones that they're most excited about. So I'd like to welcome Andy, David, and Miratul, please. It's like being Graham Norton. But I haven't got the chair that tips people out, unfortunately. Okay, so to start with, before we get into the treatments we're discussing, it'd be great to hear a little bit more about you. So could I ask you all to briefly introduce yourselves and tell the audience how you see your role in the development of new treatments for Parkinson's? David, can we start with you?
Hi, everybody. I'm David Dexter, so I'm the Research Director at Parkinson's UK. I think, not only do we find the funding for doing the clinical studies, but we're there to facilitate, to work with other organisations across the globe to try and push as hard as we can to get the research underway and get new treatments for people.
Thank you, David. Miratul?
Hello, everybody. So my name's Miratul. I'm a clinical neurologist, and I also am a researcher, and I've also been fortunate enough to be appointed the director of a new institute, a national institute that we hope will deliver discoveries, but also new ideas to come up with treatments that we can work with David and others at Parkinson's UK and other companies to really deliver for you and bring new therapies.
Thank you. Andy?
Hi, I'm Andrew Cassie. I'm a person with Parkinson's. I was diagnosed in 2010 as a young onset, age 44. But ever since that point, I'd like to think I've kind of lead by example. I've undertaken possibly 100 plus studies now and of various kinds over the years, and just like sharing that with fellow Parkinson's people to learn and lead the best possible life you can.
Amazing. Thank you, Andy. And I'm going to come to you first, actually, because Andy's taking part in a really exciting study, which is a phase 1 trial looking at the potential of stem cells for Parkinson's, which I'm sure many people have heard of stem cells, but just in case people haven't, stem cells are the original cells that we're all made from, essentially. Stem cells have the potential to become any kind of cell in the body, and scientists have been able to develop techniques that allow us to grow stem cells into dopamine-producing brain cells, and ultimately, the aim is to transplant those back into the brain to repair and replenish what's been lost. So Andy's taking part in a study called STEM-PD, which is a phase 1 trial, and which is amazing. We're going to hear more about that in a minute. But before we do, it would be great, Andy, you've mentioned you think you've taken part in over 100 studies, which is unbelievable. It would be great to hear how you started and how you got to this point where you're in this really pioneering study.
Well, it all started with my neurologist, actually, Dr. Manji. One of his students, Michelle Hu, had just starting a trial at Oxford Longitudinal Study. And so although I'm based in the East Coast in Ipswich, I would gladly sort of travel to Oxford to be part of that and share my, I'm the expert in my Parkinson's, so to share that experience with the research team. But also through that exercise, I get feedback in terms of how I perform at each, it's about 18 months interval, they do the assessments. So it's kind of a two-way learning. I found that really helpful. It makes me feel in control of or at least understanding what's happening. And so I can always got Parkinson's to blame it on when I get into trouble with my wife.
And how did it get to the point, so that, you started with doing things like observational studies where, not taking anything new, but sort of progressing. How did you get involved in STEM-PD?
Well, when I declared that I got the condition to my employer, the company doctor actually said, get involved with research because there's nothing at come along since, levodopa and then DBS, 20 years before that. So, if you want a cure, you need to be part of it. And so that's really what's been driving me ever since then. And I think my first Parkon event was 2012 up in York. I'm sure many of you have perhaps been there or have been involved as well. But the Trans-Euro study, as a precursor to STEM-PD, that started around the same time. So, and again, for a similar reason for myself, I was happy to contribute my data and information into that research team, more as a cohort than to expect to have a treatment. That's the last thing, really. I didn't expect to have that opportunity. It's quite daunting, actually, if you think about it. So every 6 months since then, I've been going back to Addenbrooke's and doing the barrage of tests that many of you will have done before for various assessments with your GPs and neurologists. And I was given the chance twice, actually, once in 2015 as the Trans-Euro study, where using fetal cells, but there were issues with the quality and quantity of those cells, and so effectively they kind of stopped or paused that particular thread and relaunched it as a STEM-PD using manufactured cells, essentially, which itself must have been a science and patience to actually work out that secret recipe to convert the cells into the dopaminergic ones we need to replace in the brains. But the first time I was just too early in my Parkinson's and not quite ready, with the family and work to take part. But the second time I was invited to take part last year. I was in the right place for me at the right time, and I felt as well that the study was a much better shape, and it felt just the right thing to do. And after being involved with all that time, to being given the opportunity and not go ahead would have, it wouldn't feel right in a way.
It's absolutely amazing, and you've been telling me about the experience of being involved in STEM-PD, and it sounds amazing, but also really challenging. Do you want to tell everyone a bit about what's actually involved?
Well, it's quite a lot. I mean, not only do you have to travel to Cambridge, I'm fortunate to live on the coast in Suffolk, so it's manageable for a day's trip there and the back. But for the initial selection, as I say, to have contributed 12 years worth of data and to then be chosen, you don't volunteer for this. It's a very specific, just now working towards personalised medicine, or treatments. It's important you give the right treatment to the right person for the right conditions, so you get a greater success then in the trials. So, as I say, to turn them down at that point would have seemed a bit churlish, really. Although, as I say, it's quite daunting, and maybe if I'd been number 1 of 8, that's the number of people in this phase 1 study, that would have been a much harder decision to make for the first in-human trial. They've proven and shown all the tests that they've done to try and minimize and eliminate all the risks that they know about. And I was convinced by the evidence, the work that all these researchers and scientists and neurologists had done to take part. So that was the initial selection. During the screening then, I mean, it's not guaranteed you're going to carry on and be part of it. They need to make sure that the details are right. There's various things that maybe in the blood or body that might interfere with the research in some way. So I need to make sure that all those things were checked, as well as scans and optional lumbar puncture. And I don't know if I don't want to put anybody off a lumbar puncture, but that's the closest they can get to the brain without taking it out of your head at the minute. So I felt that was really important to go ahead with that. I've had them before and they've been fine, but I had one incident where I had a 5-day headache, basically, which can be a known side effect of this. And the only way to alleviate it was just to lie flat on the floor. Nothing else. I've not had any kind of headache like it before. And that really made me consider if this is just a lumbar puncture, what's the surgery going to be like? But I'm pleased to report, well, A, I was very unlucky to get the headache. But it does eventually clear. But B, the surgery was the least of my worries. It's basically the same as DBS, which they've done for years now, and it's kind of the gold standard, and all the neurologists are very expert in that. So having been convinced to go ahead, I had to travel to Sweden in Lund University, where the world experts essentially then weave their magic, and just 5 days, 5 days preparation, and then 5 days sort of post-surgery to, this is me on about day 1 or 2 in the isolation ward, just to make sure the greater chance of the cells surviving. You have to be on immunosuppressants for a year. And I'm just at the stage now, I've just had my month 12 scans and assessments, and I'm now starting to come off those transplant medications. So that really was the hardest part, and being off for some of these scans as well for up to 90 minutes.
Yeah.
When getting restless legs, it's worse than a tremor for those of you that have not experienced that. Really twitchy legs, and trying to keep your head straight for that amount of time was quite a feat, but I think I managed to get through that.
So completely Herculean effort, not just from you, but from the whole team, I think.
Everybody, but they were all, I had no qualms at all about the professionalship or the risks essentially involved, and there's still unknown unknowns which may or may not arise. So, but I was just glad to be moving this part of research forward.
Absolutely, and and we should say as well, like, this is not just the only stem cell trial happening in Parkinson's. There's actually many happening around the world at different stages. And so far, the results from ones that have delivered results have looked very positive in that so far the treatment appears to be safe. And also there are some very early, very tentative signs that the stem cell therapy might be helping to improve function in the brain. So it's very exciting.
If I can just add to that, just to manage people's expectations, because this being a biological process, essentially, you can't fast track having had the cells transplanted. You've then got to let them mature and grow and weave those networks, that mesh across your brain, and that takes several years before it's fully developed, and hopefully it'll carry on as it is. But as far as I'm concerned, the fact that I'm here is a success factor, and all the other signs are looking positive.
Amazing. Well, I think we should give a round of applause to Andy. And maybe we'll have Andy back next year to see how it's going. We'll see. But we should now move on. And Rattle, you wanted to talk about treatments based on genetics. Can you tell us why you think this is such an exciting avenue for new treatments?
Yeah, thank you very much, Claire. And so Parkinson's, as we all know, is a very complex condition. We think there are different forms of Parkinson's. I mean, I certainly see patients, and I'm convinced that Parkinson's is a myriad of many different pathways that are going wrong. And Claire highlighted very nicely the different types of problems that a cell in the brain can encounter that it can't then remedy, and that might lead to Parkinson's. And I remember as a student being asked or being told, in textbooks, we don't know what the cause of Parkinson's is. So as a researcher, if we want to develop treatments that really can work, we first need to, I guess, figure out the cause. And I think as a community, we can learn, at least from medical researchers working in Parkinson's, I think we can learn from other fields and see how they've faced similar challenges and what happened. And I like the example of cancer. If we had been having this conversation in the 1970s, people at that time weren't sure about why people were developing cancers. They knew things in the environment like being exposed to radiation or certain toxins could cause cancer. They didn't really at that time know much about genetics. But in the early 1980s, the first cancer genes were discovered in humans to be causing, not in everybody with cancer, but in very rare families, they were developing cancer because of a gene mutation. And it turns out in the cancer field, they've studied what those genes do. They've developed maps or atlases of how cancer cells derive from those gene perturbations. And in the last 20 years, there are many drugs for cancer now that can significantly treat cancer based on understanding of the genes. And I think what's very important is, whilst those cancer families were very rare, you might, for example, think of Angelina Jolie. She has a mutation in a breast cancer gene called BRCA1. It's a very rare gene. Not everybody with breast cancer has BRCA1, but it turns out the pathways of BRCA1 can still operate in other people who don't have the gene. And so the treatments that have arisen from those cancer family studies can also help others. So that's me just setting the scene as to why I think understanding the genetics of a complex condition can potentially help us in Parkinson's if we look to that field. So if I now come back to obviously what we're most concerned about, which is Parkinson's. First thing to say is that British scientists, Britain has punched well above its weight in contributing to the identification of many of the genes that we know are linked to Parkinson's. Scientists in Cambridge and London particularly have been very impactful in studying rare families with Parkinson's. And so it is a very rare. So I think Parkinson's UK have recently worked with a person with Parkinson's, Jenna Douglas, to come up with some new information about Parkinson's genetics. But I think 1 in 8 people with Parkinson's probably have quite a significant genetic contribution. That means that many don't, but nevertheless, we can take the genes that are involved in Parkinson's and try and see if we can make progress to develop new treatments. And so one of the genes that has been found was what Claire mentioned, was alpha-synuclein, which was the protein that's in the brains of people with Parkinson's, and it's forming these clumps. And the clumps disturb and damage the brain cells. And this is a good example where there are actually very few families in the world that actually have the gene for the kind of the disruption of the gene. But the protein we know, the actual message that it produces, is actually quite common to many people with Parkinson's. And it's been shown that protein can assemble in a way which is, it forms effectively lots of assemblies which the cell really can't deal with. And what's been very exciting is taking that knowledge and trying to develop a treatment. And many people have shown in artificial animals experimental systems that if you can make antibodies against that protein, a bit like how most of us here will have had vaccinations against pathogens for preventing infections, you can similarly engineer strategies to make antibodies against proteins such as alpha-synuclein. And it turns out those antibodies will attack those proteins and remove them and clear them. And I think that certainly in animal models, this has turned out to be very effective at helping clear the damaging form of synuclein. And this has led to many companies pursuing that as a way to potentially arrest and halt Parkinson's. And I wanted to raise this because I think, Claire mentioned there are 3 companies that are in phase 3, and I wasn't sure if that includes the about to launch trial.
Actually.
It doesn't. So there's a 4th that's coming, and I think this is very, very relevant in now because, to do trials, it takes, as we've seen, and obviously, we need you actually to. Without you, we can't do trials. Without Andy and others, we can't do the trials. But the whole infrastructure is Herculean. But Roche, which is a Swiss company, a very good company that makes many different types of medicines for many different diseases, they have actually undertaken quite significant trials already on a molecule or an antibody to reduce alpha-synuclein. And this is now going to be entering phase 3. And in terms of the timeline of what Claire said, it turns out taking these antibodies appears to be safe, so it passed phase 1. And then the phase 2 studies that Roche undertook, they undertook them in people that were on some treatment, not much, but some treatment. And then they also undertook them on people that weren't really on any treatment at all. And that was the phase 2. And whilst those trials didn't meet their original clinical endpoints, there was actually sufficient evidence from other analyses that this alpha-synuclein antibody could be actually reducing Parkinson's activity and potentially could be helpful. And they've taken that, and this is where I think you need good companies who have very good people that know about clinical trials. And I think Roche is outstanding. They've taken what they've learned from phase 2, and they've designed a phase 3 study which will launch. And I was hearing actually from somebody that I think it's going to be Paraiso, I think is the name of the trial. But they've designed that phase 3 to give them best possible chance of seeing a signal that this might be the best approach. And so I think this is a very good example of how, fundamental research on genetics, a lot of what I would call heavy lifting and understanding what the gene component does can lead to potentially a very important milestone in our journey to find a cure. Now, let's all have our fingers crossed, and many of you maybe will be probably participating because there will be a number of trial sites for this trial. There are also other trials as well for alpha-synuclein, but I like all trials. As a clinician, I think it comes back to we will select people on certain criteria, but we still don't have ways to, I think, categorize everybody into the different flavors of Parkinson's that they have. But it will be interesting to see, hopefully, the group, it's a very large trial, I think it's going to be about 1,000 patients, but it'll be very interesting to see if overall, in the average, there's demonstration that the antibody, the approach, is actually beneficial. But no doubt within that, there will be people that probably don't change, but there might be people that have very striking improvements. And companies like Roche can use that information as well to learn. You learn a lot actually from doing trials. Whether they work or they don't work, these companies are very adept at learning a lot. So that was actually one thing I wanted to really highlight as an exemplar of a lot of work going from gene to clinic. So that was my first example.
Thank you. Thanks, Miratul. I think we'll move. That's such a great example, and I think it's one of the most promising studies in terms of this new phase 3, something that genuinely could slow the course of Parkinson's, and because it's entering phase 3, it's one of the closest things potentially to becoming available. So I think we'll move on now to talk to David about mitochondria. David, why do you think we should talk about mitochondria? Why are they so, and what treatments are being developed?
As you mentioned in your introduction, all the cells in our body need energy. It's just like your mobile phone. If you run out of energy, you can't make your calls. And it's just like that inside your cells. If you run out of energy inside the cells, they can't function properly. So mitochondria are key to the functions. And in Parkinson's, they've been shown to go wrong. One of the problems is that naughty protein, alpha-synuclein, misfolds and it punctures holes inside the mitochondria, stops them working. So one of the drugs that I'm going to talk about is, both of them are actually funded through our Parkinson's virtual biotech. In previous years, many years ago, we'd fund academics in universities to develop drugs, and then they'd get picked up by pharmaceutical companies. But that source of funding in early stage drug development dried up. So we developed the virtual biotech to really plug that gap, to take them on further, to de-risk them so people could partner with pharmaceutical companies later on. And NRG Therapeutics is a good example about where this process is working well. So these were three scientists who came to us with an idea, sort of tail end of 2018, so we started funding them in 2019. And basically, they're designing this drug to plug up that hole in the mitochondria so that they can start to function normally again. So they just came to us with this idea. It was just on paper. They hadn't got any chemicals at all. And that has really progressed well. So they've just secured a 50 million of what's called a Series B that will take it into safety testing into humans, and then also into people with Parkinson's, but also into people with motor neuron disease. So this could be a double win for this company, because this drug is shown to be effective in both motor neuron disease and in Parkinson's as well. So the second example is normally when the mitochondria start to go defective, they need recycling, just like your batteries. Once they run out in your remote control for your TV, and you haven't got the rechargeable ones, you send them off to be recycled. And the cell is exactly the same. If a mitochondria is defective, normally you recycle it and clear it out the way. But in Parkinson's, those damaged mitochondria are hanging around. So we've done funding for another company called Mission Therapeutics. And this drug will actually help promote the recycling of the mitochondria, so you get the bad ones out of the way, so new ones can be synthesized within inside the cell, and so the cell then gets its energy back again.
Brilliant. And both of those trials we expect to be starting next year, I think. Is that right?
Yes, well, in fact, the NRG Therapeutics one, the healthy volunteers will start to be given the compound in December, and then in the first part of 2026, people with Parkinson's will actually start taking them as well. So this is really exciting news, and it's done in such a short period of time. If you think about it, normally these would take many, many years. They started work in 2019, and in 2025, we've got drugs being given to patients.
Which is fantastic. Really, really exciting. And before we get to the discussion, we should also talk about a very exciting study which launched just last week. Hopefully many people have already heard about it, but it's called the EJS ACT-PD study. And David, would you be able to just briefly explain, simply if you can, why this is so exciting and different, world-leading in fact?
Yeah, so this is a real pioneering study. So traditionally, you take an active drug and you compare it against a dummy drug called a placebo. So you raise the money for the clinical trial, you develop the infrastructure across the UK, you run the study, you dismantle the infrastructure, and that is a very slow, expensive process. It's like you needing to build a football stadium every time you want to play a game of football. That's nonsense. So really what we want to do is build a network of clinical trial centres across the UK, and rather than just comparing one drug against another, is to compare multiple drugs in parallel. So that way, basically, you can actually assess whether a drug is starting to be effective or not, and if you're not seeing any signs of effectiveness, you can actually stop that drug there. So in the top panel there, you can see, in drug A, it's hit the buffers. So you stop it rather than let it go all the way through. And so you bring in a new drug. And so you can test these drugs in parallel. It's much faster. So the infrastructure stays in place. So this trial will be operating in 49 centres across the UK, whereas traditionally it's done in about a dozen centres across the UK. And also the criteria for people to join this trial are much broader, so it makes it available for most people with Parkinson's who are stable on their medication, and a lot of it can be done at home. So this is a really revolutionary way of doing clinical trials.
Yeah, definitely. Very exciting. And 1,600 people ultimately will be needed to take part in this study. And it will be testing, to begin with, 3 repurposed drugs. And I wondered, Miratul, would you like to say a little bit about what those drugs are and how we think they might be beneficial for Parkinson's?
Yeah, so this is a very exciting study, and the drugs that they plan to test have been evaluated by committees who've looked at the evidence that these drugs might be beneficial in Parkinson's. They turned out, for example, the first drug, terazosin. This was a drug that was originally designed for people with enlarged prostates. And, but the actual biology of terazosin is it's a drug that can affect the batteries or the energy kind of levels of brain cells. And it's been shown that in animal models, the terazosin can actually help with alleviating at least Parkinson's types of problems in models. But what's very striking is that people are now collecting lots and lots of human data. We're in the age of big data. You can now look at data sets of thousands of people that have been on drugs and see whether they can affect other diseases. And so it turns out there's lots of data that terazosin can potentially prevent or reduce the prevalence of Parkinson's. And so this has given the committee the view that this is a drug that's worth testing. And then the other drug, telmisartan, this is actually comes from a class of drugs that many of you might actually either be taking or know about, because it turns out that we have a system in our kidneys called the renin-aldosterone system that regulates how much salt we absorb from our kidneys, which has an impact on our blood pressure. And one of the commonest drugs that people take for blood pressure is a class of drugs that affect this renin-angiotensin system. And again, if you look at the kind of these population data sets, there's evidence that these classes of drugs might affect or might reduce Parkinson's. Now, interestingly, most of the drugs we take for blood pressure, they don't cross the blood-brain barrier. So, for example, the commonest drug is called losartan. That's probably what most people have heard of for blood pressure. But that doesn't cross the blood-brain barrier. But if you look at people who've taken either telmisartan or another drug called candesartan for other conditions, that does. And so again, there's very, very good evidence or speculative evidence that this could also be working. So that's been another reasoning for that. And then finally, the other drug has been used for liver problems. And again, similar to what I've said for the other 2 examples, the committee has deemed that whilst it was used for liver problems, there's potential for this to be done. But now, instead of looking at data kind of retrospectively, things that had already been collected, this is going forward, and you're comparing it now side by side with a group who will not be taking these drugs. And so you're more likely to get a more definitive answer that these drugs could be able to slow down Parkinson's. So I think there are very good choices by the committee, and I would encourage again, if you're interested, to get in touch with the relative contacts.
Yes, and we have the EJS ACT-PD team here today in the conference, so go to the research stands to see them and find out more. And Andy, finally, I just want to come to you. I mean, finding 1,600 people to take part in EJS ACT-PD is going to require a lot of, we've got to find lots of people eager to take part in research. What would your advice be to people who are interested in taking part, and how should they get started?
Yeah, well, it applies to both people with Parkinson's and those without. You need these controls as well in the studies. But basically just get involved if you're not already in any kind of research. And primarily that's through, I'd point you to the Research Support Network. Again, they're here in the rooms outside. And looking on the Parkinson's UK Trial Finder website, where you can see just what, in addition to these, there are loads of other types of research activities ongoing that all need our experts. You are experts in your conditions, and they need to get that information and data in order to move things forward. So, for our own sakes, please, do what you can, get involved. Here, even signing up for things like the brain bank, as because that's important, so they can actually test when we finish with it. So what was actually going on up there? So yeah, just get involved in whichever way you can.
Brilliant. Thank you, Andy. Okay, well, I think that means it's time for us to come to you guys and try and answer as many questions as we have in the time remaining. Emma, do we have any online questions?
We do. We have lots of questions from our online audience. Suzanne has asked, when is the right time for getting stem cells? What are the selection criteria?
When is the right time for getting, as in getting the treatment?
Well, at the minute, you can perhaps when they do start the next phase, eventually you'll be able to volunteer to become part of that, but they will then choose really who's best suited for that particular treatment. But they need all people to get involved, and hopefully sometime during 2026 there'll be a follow-on to the STEM PD trial in this country.
Yeah, and all trials will have their own criteria for the kinds of people that they're looking for. And I think the stem cell trials have tended to have quite a, people who've had Parkinson's for some time, not people who are newly diagnosed. But that might change and hopefully broaden as the trials progress.
So it's probably going to be something like DBS was originally utilised in people with advanced conditions, but then gradually they're bringing usage into people who've had Parkinson's for shorter periods, and that will be the same for the stem cell trials as well.
Yeah, definitely. Great question. We've got one in the room. Yes?
Hi. In 2022, I took part in a phase 1B trial on 138 and B. And it was the phase 1B, and phase 1A is published, and phase 2 is apparently taking place, but they haven't published the results of our 1B. And I'm wondering, how do I get access? How do I find out where phase 2 is, and what happened to that particular drug?
Gosh, that's such a good question. And the drug definitely rings a bell with me. And one of the things we're really passionate about at Parkinson's UK is that people who take part in studies should automatically find out what the results are. You shouldn't have to go looking for them. The research team or company or whoever it was who did the trial should be keeping you informed about the onward steps. And so I'm really sorry that hasn't happened. When it doesn't happen, I would recommend always getting in touch with us, because we can go and try and find out what we can. And we can also, if we can put a little bit of pressure sometimes on the research teams, on the companies, and say they need to do better. Because we're only going to encourage people to take part in research if we are telling people about the results and the impact of research and where it's going. And that's a part that sometimes doesn't happen as well as it should. But I don't know if anyone here knows off the top of their head anything about that particular drug. Maybe
I'm
not.
sorry, I don't.
No,
Yeah,
but
it has gone into phase 2, and that is currently running. But we can check. So there is, we can check who the coordinator of the phase 1B study that you took part in, and we can chase that up. Yeah.
That's really important, because for the patients, it can be quite invasive, and it can be a difficult process at times. So it's important we get that feedback.
yeah, it feels like the least people can do is to tell you what happened.
Yeah.
So thank you for that question. We have another one in the room. Yes?
Firstly, thank you very much for what was a very informative session. I think it's really useful to understand where we are in the pipelines and what the process looks like. I think one of the questions that I have, and you mentioned it earlier when talking about cancer, cancer is a very broad term, but there's obviously lots of specific types of cancer and lots of specific factors to the way that the products that are used activate, I guess. I think from my perspective, we talk on one hand about having exclusion criteria for clinical trials.
Oh.
Is that better?
Oh, you're back. Yes, carry on.
God, the microphone's as broken as I am. What I was wondering is, we've got exclusion criteria for clinical trials, yet we don't have definitions of different types of Parkinson's. And so at the moment we have Parkinson's or young onset and not a lot else, maybe genetic or familial. But it seems to be that until we have definitions of the types that we are, we're not a disease, we're a syndrome, we're a disorder, we're multifactorial, we're all different. And it's one of the unique areas of Parkinson's that makes me kind of thankful that I've got it, but on the other hand, annoyed that I've got it because there is no treatment that specifically targets me.
Yeah, great question. Would you like to take a start at it,
Yes,
David?
yeah. Parkinson's UK has funded a lot of what we call longitudinal studies, where people have been followed from diagnosis to many years. The Oxford group have done a big study, and we were both at a meeting on Monday and Tuesday where they were looking, because now they've followed these people up for up to 18 years now. And so now they can actually look to see whether they can start to subtype people with their Parkinson's. And they think they can see 4 basic subtypes of people. They have different features of their Parkinson's, they progress at different rates. And so then we can actually study those subgroups of people to see, if there's any clues about what is actually causing their problems. Is it more of a fault with their batteries? Is it more of a fault with their recycling? Because then you might be able to, do some targeted therapies and say, well, this drug that we're developing, may be more suitable for those people with that type of Parkinson's. So I think we're getting there. We've done a lot of the groundwork. There's a lot of exciting data on these cohorts that's been followed, and now there's some exciting work on identifying biomarkers and things that might be able to help us subtype people with Parkinson's.
Would you like to add?
Yeah, no, I mean, that's a great question, and I don't have much to add to what David has said, but people are working hard on it. So in some ways, the genetics that I mentioned that we're leveraging for treatments, people are also trying to leverage that to figure out ways to probe samples of people with Parkinson's for what are called biomarkers, so that we can give you exactly what you're looking for is what's my subtype of Parkinson's, and therefore that would help us design more targeted trials for people, the right drugs for the right people.
Thank you very much. Yes?
A few questions from our online audience about Ambroxol. So Suzanne is wondering, can you talk a bit about the Ambroxol drug? And Judith has said, has Ambroxol shown that it slows down the progression of the disease?
Great question. David, I'm going to ask you to answer that one.
Yeah, Ambroxol is another example of repurposing. So this was a component of a cough mixture that's been around for many years. So it's safe. But you need Ambroxol at a higher concentration that's present in a cough mixture. But what was shown recently was that the Ambroxol helps the cell clear those clumps of alpha-synuclein out of the way and into the recycling area. So this is a very exciting drug. So this has gone into phase 3. So there was a study called a phase 2 study, a smaller one, which was shown that it had the promising signs that it was slowing Parkinson's. So this has gone into a larger study now involving almost 400 people with Parkinson's. Some of them carry a G mutation for GBA, so that's a genetic risk factor for Parkinson's. But the other half of the people in the study have what we call idiopathic or naturally occurring Parkinson's, and that has just started to recruit patients as well.
Yeah, and that's a study we're co-funding, right?
That's correct, yeah.
Yeah. So very exciting that that's got to phase 3.
Can I just add to that as well?
Please
a
do.
word of warning for Parkinson's people. Don't go out and buy litres of the cough medicines.
Yeah, because you'd need buckets full of it.
Yeah, but do join the study so you're in a safe environment that's well controlled, and with typically the world experts in that field. Citizen science is, don't do that, especially with stem cell treatments.
Yeah. So through there's a thing called PD Frontline. So you can register for PD Frontline, and they're doing the screening for the Ambroxol trial through that process. Yeah.
I just wanted to add something just to give another plug is so that Ambroxol works on a pathway for recycling. There's also another pathway which I didn't have time to talk about, but that is called the LRK2 pathway. You'll probably see that there are quite a few trials for LRK2. And that isn't repurposing. Those are actually original targeted trials for this molecule. But in principle, it's working in the same type of problem in the cell, which is to sort of boost recycling ability.
Lovely. Question over here.
Hi, Claire.
Hi.
Hi, Claire. I just wanted, could I ask a question of Professor Miracle, please? In your new role as the lead for the new Parkinson Centre, can we understand a little bit more about how that centre will fit into us following and understanding what research is going on, what that centre's role will be?
Yeah, thank you very much. So yeah, first of all, I should have said at the beginning, we are really grateful to everyone in Parkinson's UK, the whole organisation and community, to support this new centre. It's jointly funded by Parkinson's UK and the UK DRI, which is a government-funded arm. The centre itself, I see it as being, we're going to be I would see it as being a centre that brings together researchers, not just in the centre, but across the UK. It'll be discovery-driven, so we'll be making new discoveries on Parkinson's, but we want it to also be aligned with the people with the condition. So we will have, in fact, we're going to be recruiting to the centre people with Parkinson's to act as almost as ambassadors, as a council, so that the information from the centre can be disseminated. The funding we have is for 5 years. We're currently recruiting group leaders. We've had a terrific response from all over the world, not just UK, but Germany, Australia, the US. So we're very excited about recruiting some fantastic researchers for the centre, but absolutely going forward, whatever we will be doing, we want to harmonise that, and the information is key. And so what you're asking is we will have ways through communications and interaction with Parkinson's UK to make sure that you can learn and maybe even participate in how the centre works. Is that helping to answer your question?
Lovely. I'm so sorry for people who've got their hands up and for people online with questions. I'm afraid we have to bring the session to a close. I feel like we could go on literally all day, and I would love that, but you probably want lunch. But just to finish, I want to ask my lovely guests to just share very briefly, what do you hope people who've come to this session leave with today? What's the one takeaway you would like? Andy, go ahead.
I'd like to start, just you've got to be in it to win it. If we need a cure or some way to move things forward, do what you can.
Well said, well said. Miracle?
I think this is an extremely exciting time for research that could be delivering treatments for people with Parkinson's.
Great.
I think the positivity is that there are drugs available for people to take now, which could potentially slow down their Parkinson's. These are available through the clinical trials. There's many of them are running at the moment, but it offers such positivity and hope that there are things, now that people can actually take, not in the next 5 years.
Fantastic. Well, I want to say a huge thank you to my wonderful guests for today. So a big round of applause.